So, hello everybody, welcome back to the Stoke Mandeville Plastic Surgery series, supported by PLASTA UK and ICOPLAST. Today I'm delighted and honoured to introduce to you Dhruv Singhal. So Dhruv is the Director of the Beth Israel Lymphatic Center and Associate Professor at Harvard in Boston, US. So we met last year at Chang'an during the Lymphedema Symposium, and we were both helping out at the super microsurgery course. And it was really inspiring to see how you, Dhruv, you've headed your lymphedema program at Boston and pioneered the concept of immediate lymphatic reconstruction to prevent lymphedema from occurring in the first place, which makes a lot of sense to me. So this is really a very exciting and exploding field and really has the potential to, as Steve Jobs would say, make a dent in the universe. So as always, there'll be no doubt lots of questions and comments. So if everybody can jot these down in the Q&A function at the bottom of your screens, we'll get to them at the end. So Dhruv, the floor's yours. Thank you so much.
James, thank you very much. Obviously an honor to be speaking to this group. And I'll talk more about how James and I met in a minute. So the talk this morning, the schedule says immediate lymphatic reconstruction. I'm gonna come back to that term. Right now, we're going to call it the lymphatic microsurgical preventative healing approach, or LYMPHA, is what we're going to focus on for the next 45 minutes. And then we will open up for Q&A. So James and I met actually here at the 8th World Symposium for Lymphedema Surgery. He was invited kindly by Dr. Mingwei Chang to perform LYMPHA live. And James was actually involved in that case, introduced the case. He was an amazing host. So when he called me and he said, come talk about LYMPHA ILR, I couldn't say no. So James, thank you again. And I look forward to our continued relationships. I have no disclosures for this talk. Now, again, in the schedule, the name of this talk is immediate lymphatic reconstruction. And I always want to give 100% credit to Dr. Picardo and Dr. Campisis, who really developed this approach. And they originally titled this approach LYMPHA. And that is why that is my opening slide. I have talked to Dr. Picardo about this, and I believe we should be turning our terminology a little bit towards reconstruction. It is verbiage that we are more familiar with. In plastic surgery, we are reconstructive surgeons, and we are truly doing lymphatic reconstruction. I consider LYMPHA immediate lymphatic reconstruction, just like we would consider immediate breast reconstruction. And if you perform lymph node transplant and lymphovenous bypass in the chronic setting, or even debulking, I term that, and we term that in our center, delayed lymphatic reconstruction. And we wrote about this in the Journal of Surgical Oncology as a review article in 2018. And I think that this will be important as we go to advocate for reimbursement in the future. So if I may, second title slide, we're going to be talking about immediate lymphatic reconstruction, or ILR. Now, in December 2019, to put ILR in context of a lymphatic program, in December 2019, we had our description of our program here in Boston published in PRS. And PRS invited us to do a Facebook Live event. And in that Facebook Live event, they sent us an email afterwards saying that we had reached almost 5,500 people. And this paper was now one of the top 10 most viewed articles in the PRS journal website. I'm not saying this to brag. I'm saying this to show the critical need for true comprehensive lymphatic surgery programs to develop around the country, in the US, and around the world. And so I think this is a very hot topic, and it deserves a lot of attention. But how does ILR fit into this? So you can see this is what we describe in our paper, and this is the schematic of how our center runs. And as you can see, we get a referral, and we quickly try to decide, is this a traditional referral where the patient already has lymphedema? If so, they go through our medicine clinic, our therapy clinic run by our certified lymphedema therapist. They have to go through a series of tests and questions and studies. And only after they pass through those do they actually make it to the lymphatic surgeon. On the other hand, somebody who's being referred to us to prevent lymphedema, this is a very active case. This patient has an active cancer, likely advanced cancer because nodes are involved. So they must be ready to move through your center very quickly. And so in that case, they will immediately go to see a lymphatic surgeon. They will be seen by a certified lymphedema therapist to get baseline measures. We'll coordinate with surgical oncology and proceed to the OR for their extirpative procedure where they remove the lymph nodes, and we're performing the immediate bypass at that time. And then all these patients enter into our surveillance program. So then, again, the focus of this talk is only on the prevention of lymphedema or ILR or lympho. Now, this is a table from that paper in December 2019, where we actually show in our first year experience, we had 142 patients come in. And all I want you to focus on is right here. The majority of the patients were breast cancer patients. And look at this. They were almost divided equally between immediate lymphatic reconstruction, ILR, in terms of numbers, and delayed lymphatic reconstruction, or BCRL, breast cancer-related lymphedema, was 47. So one of the lessons we wrote about in the paper is if you just start a center and you offer ILR, your numbers of ILR are almost going to match your chronic lymphedema referrals, at least when you start. And over time, likely the chronic lymphedema referrals will outpace it, depending on how you build your ILR program. I want to give you some snapshots about our center right now before we do that deep dive into ILR. So our center, the BIDMC Lymphatic Center, was established in 2016. We are patient-oriented and multidisciplinary. This is really important. There's no cure for lymphedema. So we are very patient-oriented. We really spend time understanding what are our patients' goals, and do we have an operation that can match them? And we're multidisciplinary, as you could see through the flow sheet, the different clinics we have. That didn't even talk about our radiology clinics, ICG clinics, and whatnot that really form our center. I can now tell you we're approaching our 4th year. We have seen over 900 new patients for lymphedema or high-risk patients for the development of lymphedema. And what's critical to any successes that our center may or may not have had is we've had really key institutional support that has allowed our program to grow. Okay, so now that's all a prelude to the actual talk, and this is the outline where we're going to give background on ILR. We're then going to talk about the clinical aspects of ILR, some of the history behind it, and I really want to end with our most current results out of our institution, and then research. There's a lot of things about ILR. We've studied cost utility, animal models, anatomy, and we're going to dive into all of that, hopefully leaving at least 10, 15 minutes for questions at the end. And I promise you I will leave questions at the end if I have to even cut the talk short. Background. So this is a great review article, 2014, PRS, PLASTA et al., looking at the efficacy of lymph node transplant, LV bypass in the chronic setting. And these are very good numbers, right? I mean, 78% of patients who get a lymph node transplant come off compression. It's a little high in my hands, but that's still pretty good numbers. Quantitative improvement, 90% in those getting lymph node transplant. But let's be very straightforward and blunt here. I don't know a single lymphatic surgeon who walks around and says, I can cure lymphedema. None of us say that. Do we sometimes get, we hit the ball out of the park? Sure. But for the most part, we're not curing our patients, but we're significantly improving quality of life. So then if you think about lymphedema as a progressive disease, which it is, why not think about something you can do to prevent it before the train leaves the gate? And that is really what we're talking about with ILR. And the number one cause of lymphedema in the US and in England and other developed countries, frankly, is nodal extirpations. And this is a cartoon we put together demonstrating what we're saying. Is if you have all your passengers that are in the heart and they leave the heart and go all over the body via red trains, and in the evening they all want to go home via yellow and blue trains. And here you can see this represents the axilla, and here's your yellow train tracks going through the axilla. And this is essentially what a lymph node dissection is doing. It's taking the yellow train tracks offline. Why not just bypass the yellow train onto the blue train tracks right at the site of injury? And if this analogy speaks to you at all, we actually wrote a book on this. This is a cartoon book. I wrote it with the help of an amazing cartoon artist, Megan Bellinger, who's also a certified lymphedema therapist here in Massachusetts. And Miss Kathy Bates, the Academy Award-winning actress, wrote the foreword to the book. We've donated this book to Learn. Here's the website. You can get the book for free. It's very helpful for patients. And frankly, it's helpful for clinicians. Anytime I'm doing research or thinking about a new concept, I actually go back to my train analogy and say, does it make sense in the train analogy? So if this analogy speaks to you, I'd encourage you to look up this book. All right, so that's the background of what we're going to be talking about. Now let's talk about history of ILR, or immediate lymphatic reconstruction, doing a bypass right at the time of the nodal extirpation. Now, the modern history of immediate lymphatic reconstruction really begins with a breast surgeon, Dr. Klimberg, in 2007, where she described this technique called ARM, axillary reverse mapping, where she said, you know what, I know as a breast surgeon that I cause lymphedema. The number one risk of lymphedema is removing the lymph nodes in the arm. So she said, hey, you know what I'm going to do is I'm going to inject a blue dye in the arm before I do the axe dissection. And then I'm going to go in, I'm going to look for all the blue nodes because those are draining the arm, and I'm going to leave them behind. And I'm going to take the other lymph nodes. And by doing that, I'm going to reduce the rate of lymphedema. And she was right. What was the problem? The problem was the blue lymph nodes left behind approximately 18% of the time harbor metastatic breast cancer. So the lymph nodes in the axilla actually crosstalk between the arm and the breast. So the oncologic safety of arm has been challenged, and there currently are clinical trials being led by Dr. Klimberg in the US being done to study arm. But for now, the oncologic safety of that has been challenged and is being further delineated. However, using this concept, Dr. Picardo, Dr. Campisis in Italy said, wait a second, and this is where they originally described lympha, where they said, why don't we do this? Inject blue dye in the arm, go ahead and remove the lymph nodes, including the blue lymph nodes, and we're going to go find the blue afferent channels, and we're going to bypass those into a vein. And this is a schematic from their original paper describing this. And then they described 4-year follow-up where the rate of lymphedema was only 4%. Now, we'll come back to this, but this is against historical controls being closer to 26% for this cohort. So 4% was their rate, which was incredible. Columbia University was the next one to write about this here in New York, and they described a rate of 12.5%. You'll notice I've put an asterisk next to that number, only because the Columbia group presented this year showing that their rates were actually, became equivocal data. They weren't sure this was holding in long-term follow-up. That has not come to publication yet, so I am putting an asterisk on this number. In the interim, I was working on this down in Florida. For a variety of reasons, I couldn't use blue dye because our breast surgeons were using blue dye in the breast and converting from sentinel node to axillary node on the table. So I didn't want there to be blue dye being injected in 2 places. So we started using fluorescein. And this is just a video showing what we do in the operating room. This is right before the axe dissection is going to be performed. We go ahead and inject fluorescein into the dermis right here in the upper inner arm. And what you'll see here is now you're going to be looking through the microscope, looking in the axilla. The arm is here, the head is here. Here are your level 1 lymph nodes. And you turn on the filter on the microscope. It's essentially like a Woods lamp, and you can see the arm lymphatics very clearly coming out. The lymph nodes are now removed. You come back and look, and there you go. There are the 2 sites of lymphatic injury, and you can actually see the arm lymph draining right here. So what you do is you simply isolate these channels. These are anywhere between 0.2 to 0.8 millimeters in size. You do a U-stitch through the vein, spear the lymphatics, come back to the vein, and you literally just telescope the lymphatics into the vein. That's a temporary stitch. You then take the vein, secure it to the tissue around the lymphatic, remove that original U-stitch, and now you can see the dye going to here. You go ahead, you put in a tissue expander right here, you come back an hour later, and you can now see the dye is filling the entire vein, going up to the axillary vein. So in essence, what you've done is you've created a mini thoracic duct right here in the axilla. Now I want to emphasize, this is using the original technique described by Picardo and Campisi. This is an intussusception technique. This is not an end-to-end technique. And this is really important because usually the veins in the axilla tend to be significantly larger than the healthy lymphatics that have been divided during the axillary node dissection. So I actually believe the majority of the time, this is going to be the way in which you are performing this procedure if you are doing it. We then published on our early results in Florida in 2017, again, showing a rate of about 12.5%. We happen to have the same number as Columbia because we were a multiple of 8 in terms of our group as well. And now what I want to do is share our current results with you out of Beth Israel. And before I do that, and before we do that as a group, we decided we needed to go back and really define, if you're going to talk about prevention, you got to talk about baseline risk. So we went back and we looked at what's the risk of developing lymphedema after an axillary node dissection and radiation, because that is actually risk number 1 and risk number 2 for the development of lymphedema, risk number 3 being BMI. And we did a database search using PRISMA guidelines. We looked at over 3,000 patients in the literature, 19 studies. This is a key table, and all I want you to see right now is this. After an axillary lymph node dissection, your baseline risk of getting lymphedema is 14%. And this is looking at approximately 1,500 patients in the literature. If you add on regional lymph node radiation, your risk now goes to 33%. Now, if you look at the statistics on this, the number is probably closer to 26% if you want to include a lot of statistical rigor, which we should. So that's actually what I quote patients. You have about a 1 in 4 to maybe a 1 in 3 chance of getting lymphedema if you get an axillary node dissection and regional lymph node radiation. Now, just to give you an idea, about over 88% of our patients in our center, once they're getting an axillary node dissection, they're getting radiation, which is almost indefinite, almost universally regional lymph node radiation. So that is the baseline risk. So what we did currently, and this is currently in press, that meta-analysis was published in Annals of Plastic Surgery. This is currently in press in PRS. It was accepted a few weeks ago, where we looked at our current data at our center performing ILR. So we queried our REDCap database. We looked at all patients from September 2016 to February 2019. We only included those that underwent ILR. And now there are a lot of naysayers or people who have challenged this technique. And so I actually approached some of those individuals and I asked them, what would you like to see for our data to be considered robust? And one of the things they said is they don't want to see any patients who didn't have a minimum of 6-month follow-up. And of course, they had to have preoperative data. So we siphoned off any patient that we didn't have 6-month follow-up on. We retrieved all their patient data, and we looked at their demographics, cancer characteristics, intraoperative specifics, and obviously their outcomes. And this is what we came up with. So during that period of time, we attempted this in 97 patients. We attempted ILR, but the only patients that fit our criteria, and the criteria where we lost a lot of patients, frankly, was a 6 months minimum follow-up. We only had 32 patients that met that criteria. But if you look at the demographics between these groups, they're almost identical between the two. So we do feel that this is representative of our main cohort. Going over our cancer characteristics, the main thing I want to show you is 100% of these patients got an axe dissection. But if you look here at adjuvant radiotherapy, 88% got adjuvant radiotherapy. And look at this, of those, 93% got regional lymph node radiation. Again, so the baseline risk of this group should really be in that 1 to 4 to 1 and 3 range, 26 to 33%. And these were our outcomes. Our follow-up time here, you can see is 11.4 months. You can see our change in LDEX, circumferentials, perimetry. These are all the things we put our patients through. And we had 4 patients develop transient lymphedema, which we define as lymphedema within the first 6 months of the last oncologic treatment, but only 1 patient persisted here, giving us an early rate of 3%. I completely acknowledge we need to follow these patients over a longer period of time, and we are doing that, and we are keeping as close track of these patients as we can, as long as they keep coming back to see us. And we are reaching out to them and asking them to come back. Another way to represent this is in this slide where we show all 32 patients. Every circle represents a visit in our clinic. You can see the time course here. And any dark circle represents where they met the criteria for lymphedema. And you can see those here. And you can see only 1 patient in 32.5 patient years actually persisted. Obviously, again, we want to continue to follow these patients very closely. Going back to our meta-analysis, in our meta-analysis, we also looked at what was the result with lympha or ILR if you pull all that data. And this is what I want you to see. So if you look at the patients who get axillary node dissection with regional lymph node radiation, their risk again of lymphedema was 33%. But if you pull all the data of patients who had the exact same treatment with lympha, your rate was now 10%. So again, we were showing, I will note again, this is only 58 patients at the time that were reported as having lympha on top of axillary node dissection and regional lymph node radiation. Obviously, once our data goes into this, other data that I'll briefly mention goes into this, these numbers are quickly climbing in support of performing ILR in this setting. And those other, the other data I was alluding to, some of it's right here. Dr. Jorgensen wrote a really nice paper, a review article on lympha or ILR in 2017. Another one just came out a few weeks ago by Yamamoto and JRM. Another paper from Cleveland Clinic by Schwartz and his group, also advocating for immediate lymphatic reconstruction, and a nice short communication by Dr. Chang and his group recently in the Breast Journal. So again, there's more data coming into this. As James said, this is a very hot topic. I just would encourage you, if this is something you're interested in, and it's, I believe, obviously it's very worthy, but you must be objective on this because there are still questions out there. And the only way we're going to etch this in stone is if we continue to show good high-level data on the efficacy of this over time. All right, so that is really what I wanted to talk about clinically with ILR, and now I want to talk about some of the research we're doing, and it definitely looks like I'm going to be able to finish by 7:45, at which point I'd love to have, Q&A for a little bit. All right, so let's go ahead and talk about research. So one of the questions is cost. You know, when I give this talk, say every 2-3 times I give this talk, I get a question about cost. And for that reason, our group went back and we actually studied this. So we said, is lympha or ILR cost effective? And we presented this last year at the American College of Surgeons, where we worked very closely with Dr. Abhishek Chatterjee, who's chief of plastics here in Boston at Tufts. He has an MBA, and he's a cost analysis expert. And he taught us about this thing called ICER, which is the incremental cost utility ratio. It's essentially what you do is you look at the cost of a procedure, doing a procedure without lympha, cost of doing the procedure with lympha, and you divide it by quality of life. And you develop the quality of life scores by actually pooling oncologists who are familiar with lymphedema. You give them a scale of 0 to 100, and you say, okay, blindness is like, death is 0, blindness is 33, perfect quality of life is 100, and you pool them to say, where's lymphedema? And then they will give you a number, and you determine quality of life without performing lympha and quality of life by performing lympha. And you do this ratio, and you develop this additional cost associated with 1 unit of health effect or quality of life. And what's agreed in the literature is if this value is less than $50,000, the procedure you're studying is cost effective. So even if it comes back at $49,000, it's cost effective. So look at this. These were our results. In model 1, which was without radiation, it was just axe dissection with lympha. Our ICER was $1,500. So this is like crazy cost effective. And then if you add on radiation, we even went down further to $700. Again, very cost effective. So this has now been published in the Annals of Surgery. I think it was also in December of 2019, if you want to look into details of this. So that's one of the research projects we worked on. And then another one which has taken up a lot of time, it's been a year, going on to 2 years now, and we're continuing to work on this as an animal model. So I think there's a lot of questions about ILR. When I started presenting on it, many people challenged the technique for it, and I think these are all appropriate challenges. I don't think any stone should be left unturned. And so I decided, I said, look, there's no animal model for this, and we really need to develop one because there are a lot of questions. Questions about patency. What happens with radiation? What happens with chemotherapy? How do we know what we're doing works? And so the best way to study that is an animal model. So what we did, this was our problem, and this is how we decided to go after it. So we've been collaborating very closely with Dr. Swami in Australia, and he has already mapped out all the lymphatics in the swine. And as it turns out, the swine lymphatics are the closest in size to human lymphatics. So this was actually a really nice model for us to go after. So what we did is we took the hind limb, we injected H&E into the dermis, we identified a major collector, we cannulized it using a 26 gauge angiocath, secured it, and we actually did this in both hind limbs. And then what we did is we injected a different near-infrared dye, indocyanine green or Evans blue, directly into the lymphatic, into each hind limb. And as you can see here, using near-infrared imaging, each dye has a different optical property. And this is going to become critical because what we did before we injected the dyes is we put a central line into the swine, and we were able to take blood off centrally. And what we then did is we put it through a spectrometer, and we measured the fluorescence for each dye. And by doing so, you can see we can develop a clearance curve for any particular dye. So this is what I want to show you we did. In our control group, here we had the groin lymph nodes. We went ahead, we removed the lymph nodes, tied off the lymphatics, which are right here, injected our dyes, and this is what happened. As you can see, this is our control, and over 3 hours, this is 3 hours plus, you can see what happened on the control side where we did not remove lymph nodes. And this is what happened on the lymphadenectomy side. We had a 68% reduction in lymphatic clearance in real time in 3 hours following the lymphadenectomy. Now look what happened on the treatment side. On the treatment side, this is the lymphadenectomy site, but what we did was we went ahead and we did the bypass, and we did it the same way Picardo and Capisi described, as an intussusception. And we proved that it was working using near-infrared imaging. Our FLAIR device showed that the dye was actually passing through. And then this is what our curves look like. And I remember the first time I looked at this curve, I scratched my head because I didn't understand. Blue was the control, and red was the study side where we did the bypass. And I said, well, why was the study side outpacing the control side? And then it made sense. It was outpacing it because the control side still had to go through lymph nodes. But this side immediately went into central circulation. But as you could see, it still couldn't keep pace with the control side, likely because we can't bypass all the lymphatics. And for that reason, instead of a 68% reduction, there was only I just want to make sure I'm doing well on time. There was only a 21% reduction in lymphatic clearance. So we felt that this was a nice model because we started working on this technique of quantifying real-time lymphatic clearance, and we were showing in real time that we could have a drop in our clearance. And we went ahead and we wrote about this model in the Journal of Surgical Research in 2018. Based on this work, we got funding from the ASRM, Learn, and the Plastic Surgery Foundation. And we went ahead and we've actually done further studies, which will be hopefully coming out in publication in the next few months, where we realized our animal model that we just described cannot be clinically translated. I'm not about to cut a human being's arm and cannulating a lymphatic channel. So what we needed to do is we needed to use dyes that we could inject in the skin, but were really optically active. And so we collaborated with some of our colleagues at MGH who really developed lymphatic specific dyes that are very optically active. So we could just inject a little bit into the dermis, and it was very powerful enough that we could pick it up in the blood. Just to give you an idea, we were injecting multiple cc's of ICG into the lymphatic system in the original model. And that's what we wanted to move away from. The other thing is we can't put a central line and get central blood when you're doing an X dissection. So we wanted to develop a non-invasive way to image the dye concentrations in the body centrally. So we've been working on ways to actually image the skin and detecting these very optically active dyes. And this is just showing time equals 0. And we also are exposing veins elsewhere in the body to see if we can pick up on concentrations of the dye. So this is our current work. And again, we're looking forward to sharing our results shortly in publication. So that's the animal model we're working on. And finally, the last research I'm going to share with you is research that is honestly keeping me up at night because this really excites me. So I think there is a $1 million question out there. And I think if we can answer this question, we are going to be able to predict who's going to get lymphedema. And not only are we going to be able to predict who's going to get lymphedema, but I believe we can then reverse engineer how to treat patients who already have lymphedema most optimally. And that $1 million question is, why do 2/3 of patients not get lymphedema? So if you remember that baseline risk, the baseline risk of getting lymphedema is 26 to 33%. So what's going on in the other 66%? Why do they get the exact same treatment in axillary node dissection, radiation, and not get lymphedema? And this is a question that keeps me up at night. Now, if you look at the literature, there's two basic theories. When I went in the literature, I basically pulled it into two basic theories that are out there. One theory is that we talk about lymphedema as being primary or secondary. meaning you're either born with it, present at various time points in life, or you had a normal lymphatic system and then there was an insult to it. So one theory is all lymphedema is primary lymphedema. So patients who don't develop lymphedema after an axillary node, but patients who do develop lymphedema after an axillary node dissection actually have a genetic mutation of some kind that likely predispose them to the development of lymphedema after the axillary node dissection. The other theory, and this is a theory that excites me a little more, I'm a surgeon, is anatomy. That there are variations in lymphatic anatomy that predispose certain patients to the development of lymphedema. So you can see here the majority of the lymphatics of the arm are going here to the axilla, but you can see this yellow tab here is showing that there are lymphatics here that bypass the axilla, and that's called the Mascagni-Sappi pathway in this particular instance. And Dr. Pisas, an anatomist from France, actually came to our symposium in 2017 and presented an abstract where he said, this is the reason patients develop lymphedema. And I have to tell you, there's no question in my mind now that this is at least part of the answer. Because I have seen patients come in with chronic lymphedema where you look and they had a skin cancer removed out here where the Sappi pathway would normally run. So they knocked out their backup pathway. They had an axe dissection and they developed lymphedema. And this is what Pisas was commenting on. And he said it's about the Sappi pathway. So I have to share this story because I remember a couple of years ago, this is after hearing Pisas talk, I was sitting in my office and I said, okay, I got to go learn more about the Sappi pathway. I called our library, Countway Library at Harvard, and I was like, look, one of the original descriptions is from 1874. Can you get me like a PDF of this or something? And I remember hearing rustling in the background, and then I hear them say, we have it. And I said, what do you mean you have it? So we have the original textbook. And I remember it was pouring rain outside, and I ran from my office to the library, to this room. It's our rare books collection, to put on special hats and stuff to go in, but this was it. I couldn't believe it. I was touching history. This was one of the original textbooks from 1874. You can see this right here. Here's the imprint, 1874. And here's the key slide if you're thinking about the upper extremity. Look at this. It's right here. So the majority of the lymphatics go here to the axilla. And here is a pathway that is completely circumventing the axilla. It's the Mascagni-Sappi pathway. Mascagni was from an anatomist who described this in 1787, and then Sappi again in 1874. Leduc in the 1900s also talks about this Sappi pathway as a backup pathway. Here it is, right here. So our group, we actually just had this accepted in cancers a couple of weeks ago, where what we say, if you can actually visualize the MS pathway, all you have to do is get an ultrasound, find the cephalic vein in the upper outer arm, and inject ICG into the skin right over it. And look at this. We picked this picture because you can actually see the vein through the skin. You can't always do that. And you can see how the lymphatic pathway is right along it. Now this is not in the vein. If it was in the vein, it would pass through very quickly. This is actually in a lymphatic channel, traveling almost identically with the vein. So now what we do with ILR is we actually inject fluorescein where the main pathways go, and then we use an ultrasound, find the cephalic vein, and inject blue dye. And in a way, we're mapping the different areas of the arm before we go do ILR. So we do an ultrasound, we find our vein, and then we inject blue dye right over the cephalic vein. This is 29 consecutive patients where we did this. What you can see is only in 3 patients, or 10% of the patients, did we ever find blue dye in the axilla. Again, speaking to anatomic variations that are likely occurring with the MS pathway. So you can see here, this is one of those cases where you can see here's the axillary vein, there's a thoracodorsal going down below, and here's the arm right here. And you can see 3 and 4 are blue lymphatics, and 1 and 2, if you look on the filter, are arm lymphatics that are fluorescein. They're coming from the main pathway. So we had mapped out each zone, and what we did, and I apologize for the blurriness of this came off our microscope media system, is we went ahead and we bypassed both the fluorescein channels and the blue channels. And here Swami put together a really nice schematic, kind of showing you what we were trying to do while we were doing this. So that is the research. In conclusion, I will say that I believe ILR has the potential of being a game changer. I want to be very cautious here. I think, again, this is exciting. Early data is very promising. Long-term data from the Italians, Dr. Picardo, Dr. Capisi, is also very promising. The Columbia group is challenging some of that long-term data. I am going to be very excited to see what our data shows. I will tell you right now, our data continues to be on the promising side of this, and we are going to do another review of this in the coming year. And I encourage you, if you are doing this, please be objective and track your outcomes over time. I also think ILR is going to be a critical vehicle in which to study lymphatic anatomy. And if we do this, I think we are going to be able to answer some questions that could knock this field out of the park. I want to thank our clinicians at the BIDMC Lymphatic Center. This is our research group. I just want to give a shout out this year to Melissa Granoff, who is our lead research fellow. Again, many of our collaborators in and around Boston. I invite you all to our symposium. It's our 4th annual this year. It was supposed to be November 2020. We have postponed it. It is now going to be November 2021. Visit our site, harvardlymphaticsurgery.org, for updates. They'll be coming up in the next few weeks. Thank you. I'd love to answer any questions. I'll try to answer them all now. If not, feel free to email, and I'll try to answer them that way. James, thanks, man.
Drew, thank you so much. That was really inspiring, and thank you for sharing your current data. I mean, to see the incidence of lymphedema going from 26 to 33%, coming right down to what, 3.5%. That even at 6 months, that's incredible. Question to you, kind of on the same vein as your anatomical studies on the MS pathway. The 3.5% who do go on to have lymphedema despite the lymphosurgery, do you think that's also an anatomical explanation? Or do you think that's more of a genetic, or do you have any feel from the data you've got so far?
Yeah, so, there's no question that the patients that we have lost, I developed lymphedema or transient lymphedema, were in the radiation group. So I think, this is all theory. But it could be radiation. I've thought about this. I think about this all the time. And I actually don't think the bypass is critical long-term. We know the lymphatic system is very robust in creating its own channels, correct? And so after an axillary node dissection, I actually believe patients develop their own channels. But for certain patients, the hit they take while they're doing that is so severe that they really do need a bypass to help them bridge that period of time. And so I don't know the answer to your question. Theories would be it's radiation injury. It's related to backup pathways. Could be technical failure. I think all of those are reasonable answers. And we need a lot more numbers and, again, more objective data from many institutions before I think I can answer that intelligently.
Sure. And any comments on possibility of using prophylactic lymph node transfer?
Yeah, this all goes back to the family test, right? When I'm doing lymphatic surgery, whether in the delayed setting or immediate setting, like I said earlier, we don't cure patients, right? In the delayed setting, and even in the immediate setting, you have to remember you're on the edge when you do this in terms of the field. So I always do the family test. Would I do this on my own family member? And I will tell you, if my 5-year-old, 3-year-old, 3-month-old, or my beautiful wife needed an axe dissection, you can bet your mortgage I would walk into that OR and do this procedure. There's no downside, okay? And the more you do it, the faster you'll get. Would I do a lymph node transplant? No, I just wouldn't. Doing what you need to do for a lymph node transplant, depending on where you take your lymph nodes, the fins have showed that there is change to the lymphatic system in that extremity if you get it from the groin or you get it from the lateral thoracic region. The only place where I think you don't cause lymphatic dysfunction in that limb is if you go to the omentum. Would I take omental, which is my go-to in the delayed setting? So would I do that in the immediate setting? No, I wouldn't give a patient a laparotomy.
Sure. Great. We've got a couple of questions on your technique of suturing lymphatics to the axillary vein. Can you explain that technique? And the second question, how many lymphatics do you use?
Great. So I'll answer the second one first because it's easy numbers. So on average, we see 3.4 lymphatics, and we bypass, I think it was 1.7. So we're between 1 to 2 lymphatics. And usually we're putting them right into one vein. But now, you know, with time, I'm getting more aggressive. I'll take side branches, as I showed later, and I'll do, you know, 2 separate sites. It's critical to understand that if you have a lymphatic and another lymphatic, as long as they're within the same diameter of the diameter of your vein, one vein can get both of them. Mm-hmm. But if they're too far away, then you need 2 separate veins. Mm-hmm. And in terms, does that make sense? And now in terms of technique, I think I'll just go back to this diagram because I think it's the clearest diagram of what we're doing. Give me 1 second. Right here. So you can see here, what we're basically doing is we take this U stitch. So we put a stitch through the anterior wall of the vein, spear the lymphatics, come back through and come back out. We tie it down. So that's a U stitch, right? Then we secure this vein to the fat around the lymphatics, and then we pull this stitch out. So essentially the lymphatics end up just sitting there when you're done. Is that good?
Great, thank you. And question from Rebecca Shirley, one of my colleagues. What do you think about doing more distal anastomoses?
Yeah, you know, so I'll tell you, a lot of people have brought this up. I've had visitors who asked me about this. One of my breast surgeons, Dr. Mary Jane Houlihan, has asked me about this. Why not, instead of going here, why not go here and do it? So, you know, I don't see a reason not to. The reason I don't do it is I see the site of injury. So I know, I see my arm lymphatics very clearly there. I'm not sure I'm ready to put more incisions on a patient. You know, one of the most common questions I ask is, when I counsel my patients, I'm very honest. Like very few people in the world have written about this. I feel very strongly about this. You know, surgery is a controlled assault on a patient, right? You're assaulting a patient to make him better. So I really tell my patients and make sure they understand the context with which they're getting the procedure. And they ask me very frequently, are you going to do another incision? And my answer is no, I'm not. I'm sticking right to what the breast surgeon did. I think if our data long-term continues to hold on this, yeah, I think we can start asking ourselves, should we go more distal? But even now, I don't see the value of it if we can do it right in the bed that's already exposed for you.
Just going back to your first, you know, your review on ILR, you also mentioned the role of ILR in gynae or lower limb lymphedema. Just wondered what your experience of that has been and how that compares with, is it as predictable or is it much more difficult?
Yeah, I've done 2 cases. Okay, so people sometimes ask me for the lower extremity, and people sometimes ask me, what's the hardest part of starting a lymphedema program? Subcorollary to that is, what's the hardest part of starting an ILR program? Is culture change. You have to get people to believe, to think differently. So our breast surgeons came on board. We had robust data, our early data coming out of Florida, which is where I was originally, and then they caught on here right away. We became so busy that only recently did we start approaching our gyne-oncs and our uro-oncs. So we're actually presenting. We presented our gyne-oncs a couple months ago, and we're presenting to our uro-oncs actually next week. So we're still getting there. I was on call for a case last week. It was a sarcoma where they had to remove basically everything, including part of the femoral artery. And by the time they were done, it was so late. The surgical oncologist said, no, no bypass, which I respect. I mean, the patient was sick. They had a lot going on. So I can't really speak to it, but if you're more interested in this, Picardo and his group have written on this. And I believe also the Japanese have now written on this. So don't quote me on that. But there's 2 papers out on this that I know
of. A question from anonymous attendee. Any higher risk of lymphocele post-op from ILR?
Great question. So lymphocele is an independent risk factor for the development of lymphedema. So if anything, so the answer is no, we haven't seen that. But if anything, even if the anastomosis doesn't work, and I think Picardo wrote about this in one of his early papers, you're going to prevent a lymphocele. Right? Because at least you've given the lymphatic a home, and you're going to prevent it from just spilling into that arm lymph that I showed in the video. You're going to prevent that from just continually spilling into the axis. But to answer your question, no, we have not seen any increased rates of lymphocele. We've absolutely seen lymphoceles, but remember now, we are dealing with patients undergoing axillary node dissection, so they're at higher risk for this. But by no means are we seeing more because of what we're doing.
Okay. A couple more questions, if you will.
Yeah.
Anonymous attendee. Can you see any side effects of performing ILR in breast cancer setting and any concerns about oncological safety?
Yeah, so side effects and safety. Sorry, I thought the first question was the second question, so let me write them both down. Okay, so first, oncologic safety. This question comes up not infrequently from patients. And what I share with them, again, I always share I would do this on my own family member, which is true. But then I also share there's never been a case report that I know of, and I have asked many breast surgeons about this, of metastatic breast cancer to the arm. So as long as there's no cancer in the arm, then there should be no reason that I can think of where it's unsafe to bypass an arm lymphatic into an axillary vein. Now, the corollary to that is I have absolutely been in the OR where I've injected my dye, I go in and I find a lymph node that's lighting up. It was a lymph node left behind by the breast surgeon. Do not bypass that lymphatic. Don't bypass that lymphatic coming off that lymph node. Call your breast surgeon back in, say there's a lymph node here, and have them remove it and go from there. But I would not bypass that because there's an 18% chance that lymph node could have metastatic breast cancer, and you don't want to give that around to the central system. Side effects, we have not seen any side effects. That said, I mean, we have seen a local reaction to some of the dyes, but the biggest side effect I tell my patients about, especially now that we're injecting isosulfan blue over the cephalic, is a dye reaction. You can have anaphylaxis. I do pre-medicate all my patients with 20 of Pepsid, 50 of Benadryl, and 100 of hydrochloric, mainly because of the isosulfan blue injection, because the very small rate of anaphylaxis from that, which we know from the breast literature. And there is good data from one of my mentors, Chen Rout, showing that giving that cocktail can mitigate, not eliminate, but mitigate the severity of an anaphylactic reaction. So I do that fairly routinely. I think it's a little overkill, but I would do it for my own family members, so I do it.
How much longer is the operation then from if you go in and do an ILR?
Yeah, so we had about 84 minutes, I think was our data, somewhere in the 80-minute range for it. Picardo, I think, had it down to 20 minutes. I remember I asked him about that. I said, how do you do this in 20 minutes? I think one of the things is because I have done a couple of cases where I only use blue dye, and it does make it faster than the fluorescein, but I now need both dyes because I'm mapping each zone. And I too think my times are now getting into the 40-minute range. Plus, I work with residents, and so I think that adds a little time as well. But I definitely think with time, you can get this down under an hour for sure.
Okay. Very good question from Evelyn Bijlard. Would you argue that patients scheduled for axillary node dissection and radiation, but who has a SAPI lymph pathway outside the axilla, do not need immediate lymph node reconstruction?
It's a great question. I'll tell you, that is what I hope our research will lead to one day. I will tell you, I don't think it's that simple. I've talked to Hiro Swami, who's really the modern lymphatic anatomy expert, right? Like the Ledukes of the 1900s, the Sappi of the 1800s, and the Scagni of the 1700s. And Swami has, Swami's taught me a lot. And one of the things Swami has said to me is he doesn't think the MS pathway alone, in and of itself, presence or absence is going to be the absolute answer. I think there are more subtleties to this if you look back at the anatomic literature, and that's what we're working to tease out. So I would not take the MS pathway as evidence that the patient's not going to get lymphedema. That is not a true statement. I think we have more to learn about the MS pathway, and that's what we're trying to do.
Okay. And final two-part question by Marlene Perez Coleman. Thank you for everything. Great talk. Is there a difference between IRR and the TLAR described by Jaume Maciet? You answer that first.
Yeah, sure. So I think the Barcelona cocktail, which is what Jaume talks about, is really where he's talking about doing, unless there's a new term, but in the cocktail, what he's talking about is doing a breast reconstruction and also a lymph node transplant, I believe, at the same time. Now, if there is a new term, one thing I know Jaume does is he will actually go, and he does this during sentinel node biopsy as well. That's the one thing. I know he's doing ILR, and he's doing it during sentinel node biopsy. I personally have not been doing that because the rate of lymphedema is so low after sentinel lymph node biopsy that I don't see the utility of spending our time in the OR doing that, especially having now seen 900 patients. I can count on one hand the numbers who only had a sentinel node biopsy and developed lymphedema. Mm. So if you're referring to the Barcelona cocktail, it's breast reconstruction, axillary reconstruction, simultaneous lymph node transplant, or if you're referring to what he's doing in the axilla, it is, I think he's doing it for sentinel node and axillary node.
Great. And so Marlene's second question was, what's your approach to compression garments? Do you only use it if they develop lymphedema?
Great question, 100%. We do not give, and anecdotally, so we do not put our patients in any compression. They do not get any treatment, ILR, and they're home. They have a drain. It comes out usually within 10 days, etc. But they don't get any specific treatment other than our very strict surveillance program, which we've written about. Now, if they develop early that transient lymphedema phase, we will put them into compression. And I think we do need to be a little cautious about thoughts of putting patients into early compression. And I only know this anecdotally. One of the groups that came to visit, I think went off, did this, and they called and they said they were getting early, the higher rates of lymphedema than normal. And when we started going through what their protocol was, I noticed that they were putting compression on right away on these patients. And I actually think what you can do is if you leave any lymphatic channels open by accident, I usually clip off anything I don't bypass, and then you put compression, you're creating a lymphocele. You're pushing fluid into the axilla and potentially potentiating a lymphocele, which would increase your lymphedema rates. So again, that's completely anecdotal, but I would not recommend any compression in these patients early on, unless you're concerned in your surveillance program.
Brilliant. I think that's all the questions.
All right, James. Thanks for having me, man. This was awesome.
Fantastic talk.
Thank you very much. It was an honor being here. I wish everyone safe passage through these crazy times. We will get through this together for sure.
Lovely to see you again, and I'll give you a shout. I'll come to Boston at some point.
That would be awesome, man. You take care. Good luck with the kids.
Cheers, you too. Bye.
Bye.